Good afternoon, everyone. I'm Branko Ristic, PhD student under the supervision of Professor Sara Tozat. Today I'm going to talk about my study, Quality of Life in Rheumatic Disease. That study is the part of collaborative project between the areas of psychiatry and rheumatology, where we were focusing on three most common rheumatic diseases, such as rheumatoid arthritis, psoriatic arthritis, and spondyloarthritis. So the patient needed to have one of those three diagnoses to have 18 years or to be older, and to have clinically stable illness. Exclusion criteria were diagnosis of the other illnesses, and all the projects have been done in the University Hospital of Verona. The recruitment period around 1 year, and during the routine outpatient visit, we were collecting all the data. In the present study, I had two aims. One, to compare the impairment of quality of life among those three diagnoses that I mentioned, and to explore does socio-demographic and clinical variables influence on physical and mental quality of life. In that purpose, I used a few instruments. For measuring quality of life, I used SF36 that has two areas: the measuring physical quality of life, telling us the ability of how much the patient can perform everyday physical activities, and mental quality of life, where the patient is expressing how stable emotional life does he or she has, and how about the ability to perform everyday social activities. Then, talking about disease activity, we were measuring it with three instruments for each of diagnoses, and that's a common instrument used in clinical practice for measuring how strong is the illness in some specific moment. Then depression and anxiety we measure with HAT that evaluates the severity and depressive and anxiety symptoms. Then our clinical sample was consisted of 807 participants. That means that it was a huge cohort of the patients, and most of them, more than 60%, had rheumatoid arthritis. Then more than 70% were females, and 75% had over 50 years. So now focusing on our main results, differences in physical quality of life expressed between rheumatoid arthritis that had lower physical quality of life than spondyloarthritis, while psoriatic arthritis didn't express differences between comparing to the other two diagnoses. Differences in mental quality of life were not significant. They were quite the same. Then we were focusing on determinants of physical and mental quality of life. The main determinant of physical quality of life was disease activity that decreased physical quality of life. That means that the strong disease, expressing that the patient hardly moved their joints, is explaining between 30 and 50% of physical quality of life, decreasing it. Then main determinants of mental quality of life were depression and anxiety, where the strong symptoms of depression and anxiety symptoms decrease mental quality of life, and they had strong influence. They were explaining between, let's say, about 30 and 43% of mental quality of life. What that means in everyday practice, that controlling the illness over the effective treatment, that the patient is respecting, that the patient is adherent toward the treatment. That means that with that behavior, he or she will improve physical quality of life. The second important message is that the patient with rheumatic disease should be aware that depression and anxiety could be consequences of the chronic illness, and that it's treatable. So they should be aware that if they feel sad or nervous, that could be normal reaction on the illness, and that it's treatable, and with that treatment, they could increase their mental quality of life, and it's treatable. So in a way that physician should find out in their clinical practice, or to work in group with with the mental health professionals, and thought the patient should work also with psychiatrists or clinical psychologists, improving their mental quality of life. That would be all. Thank you for your attention.